System science is not about the pieces. It's not about understanding those pieces in a highly reductionist way where we take them apart and try to understand those mechanisms. That's great stuff. It's extremely important, and there's lots of good investments going on. But really, system science is about the synthesis. It's about putting the pieces together and seeing their joint implications. And that's a science which is much newer in its creation. It's kind of like you can be an amazing car mechanic. Now, all there is to know about tires and car engines and fuel injection systems and exhaust manifolds, etc., and you'll know absolutely nothing about traffic jams. This is about the traffic jams. This is not about the pieces, but about how they relate to form the patterns at the high level, and about reasoning through that so we can make better decisions. So we're going to be talking about the primary vehicle for those decision-making, which is dynamic models, and talk about shared characteristics of dynamic models. Now, we're then, and this will probably be something we'll pursue after lunch, most fundamentally going to talk about three types of system science methods, what are called system dynamics modeling, agent-based modeling, and process-centric modeling, which often goes by the term discrete event modeling, although each of these terms has some imperfect character. So I'm going to spend a little bit more time on this issue of dynamic models and system science and the motivation. I talked about many aspects of this motivation earlier, and I don't want to belabor it. Fundamentally, in this world, we're seeking to, within the health sphere, redirect the course of change in the sense of improving things. We're hoping to improve the quality, the timeliness, and the extent of the care that we can offer within our health care systems. We're seeking to achieve the triple aim articulated by Don Berwick. And we're seeking to do so in a complex environment with lots of things going on, lots of challenges, from demographics to issues having concerned with the economics of the situation, uncertainties on the political and economic realm. And we're trying to make a difference fundamentally in the context of complexity. And, whether it goes from one area to the other, diabetes, obesity, oral health, heart disease, and tobacco, or issues in developmental health, we're often dealing with real challenges that bedevil simple decision-making. We're dealing with the entanglement of many issues, and in the area of infant-child mental health, for example, where I work, you have these interactions of service delivery on many different areas needing to address developmental needs. So folks who come in from the mental health side, from early child care and education, folks from developmental disability side, that often need to be brought to the table to coordinate care effectively. So we're dealing with great systemic complexity in terms of the healthcare system, as well as in terms of the health conditions and risk factors being considered. So we have a variety of factors that come to the fore in many, many areas of health that I won't belabor, but I think it's a familiar feature when we're trying to make change for the better. Now, reductionist approaches that seek to study and better understand the mechanisms in great detail, have been extremely valuable for alerting us to a wide variety of very important knowledge concerning biomedical understanding. And traditionally, scientific approaches have pursued this strategy to good insight. And in the modern healthcare system, if you want to have a bone set appropriately, or you want to have congestive heart failure dealt with most effectively, you're going to be drawing very strongly on sort of traditional scientific knowledge is built up through reductionist approaches, and it's very powerful stuff. But this sort of strategy is left limited insight as to how all these pieces fit together, how you take that understanding biomedically and you put it into the context of people's life constraints, into the context of opportunity structures, into the context of a health care system and allied health professions that work together in very, very complex ways. And often what challenges us is that we need to understand how these pieces fit together with confidence in order to make effective policy, to put in place fixes that stay fixed, as Jeff tends to put it. So if we want to reliably understand policy trade-offs, if we want to be able to reliably improve and move towards this triple aim in health care, we need to be able to understand how these pieces fit together so when we undertake an action, we're not smacked in the face due to unintended consequences. So we're seeking here to arrive at fixes that stay fixed, fixes that are high leverage, cost-effective, robust given the uncertainties. And to do so, we need to understand how these different areas of the system relate to one another so that we can make effective decisions that won't have big side effects we didn't realize. So I think I'll skip through this, but one of the major insights that come in these areas is that interaction of very simple components can sometimes lead to emergent patterns that are surprising. Sometimes you take two components of the healthcare system that are each put together in very sensible ways, and you find they work at cross purposes. You find that, as Don Berwick described very vividly, clinicians who try to optimize their particular area of the system often end up running afoul of overall system behavior, actually worsening things for others, squeezing the balloon here, it pops out there, or working at cross purposes in terms of not optimizing overall system function. So it may be through attempts to push beds to other wards. It may be through attempts to streamline processes and increase throughput that actually lowers the quality of care delivered, which needs to be then remediated downstream. And as a result, you can have these changes which seem well motivated and thought through at a local level, which have these undesirable consequences across the system as a whole. And there's a long history of examples of this in the health space that I don't have time to go into, but cases where there's been these blowback effects from interventions that have yielded adverse consequences. I think I'm going to skip through most of this. Why is this important? Why is this complexity important? Well, it turns out that it leads to counterintuitive behavior when we undertake interventions. We're surprised by the consequences of our actions. We undertake an action we think makes a lot of sense based on pilot work, and it doesn't come to scale. It falls disappointingly short when it's scaled up. Or we undertake it and we don't see effects soon enough to really enhance credibility on the part of policymakers. We misperceive how the system works. We take evidence from the system and we're not sure how to interpret it, and sometimes we misinterpret it in terms of whether it's even good versus bad. There's some very interesting cases in the STI front of that sort. We see what is called policy resistance, a situation where we undertake a change in one area of the system and it actually causes changes in other areas that push back against the effectiveness. And yet, at the same time, we see situations where there are tipping points, where if we can make enough of an investment, very similar to what Jenny was talking about earlier, if we can make enough of a difference, it will totally change the character of the situation. We go from a situation of constantly fighting fires in a dementia ward, constantly dealing with this new acting out of aggression, to a situation where those problems are spotted early by an experienced nurse who handles the situation, and now we have a very smoothly running ward. There are tipping points in behavior. There are situations where you can get a system to a point where there's a qualitative change. And conversely, there's tipping points in the adverse direction, where what has been a fairly successful situation till now starts going awry, starts going off course in a dramatic way. All these phenomena pose real problems for several things. Learning from experience. How do we learn from the experience of Toronto and apply it in Moose Jaw? How do we coordinate our actions? Different parties at different pieces of a system. How do they work together most effectively so they're not working at cross purposes, rather they're working in a coordinated fashion that accomplishes shared goals. It raises problems for planning and deciding how to structure a system, for example, so that the incentives are in place, so that the system as a whole works well and in a consistent fashion. So the risk here, and this is an analogy first raised by Jeff to my attention, but I like the analogy, and it harks back to King Canute, who some of you may have known as a king in England prior to the Norman invasion, who was said to have been baited by his advisors that he could order any law in the kingdom, and the kingdom would obey. And he said, well, there's certain things I can't order effectively, right? And they said, well, no, anything is under your control. He said, well, if I order back the tide, it's not going to be very effective, right? If I set a law against the tide, it's not going to be an effective strategy. And he proceeded to demonstrate it, ordering back the tide and seeing no effects. And we're often in a situation where we're working at cross purposes with the nature of things. We're working at cross purposes with how things are, and we can't expect big gains unless we're savvy about how things work out there. So the realization that's at the heart of dynamic modeling is to really make an effect, we need to understand how things are working in the world, or at least have some theory about why we see the patterns that we do. So we have lots and lots of empirical data, and ever more so these days in this growing age of big data. Data from traditional data sources, billing, hospitalization, pharmaceutical prescription data, such as in Saskatchewan's administrative databases, but also data from clinical charts, from surveys that have been conducted, from primary data collection by clinicians or others. These bring in large amounts of data, and these days, with the rise of electronic health records, we can draw on ever more and ever-growing amounts of data. But the data that we're collecting fundamentally are reflective of underlying processes. There's some processes out there, processes involving health and health care, that give rise to this data. And as I talked about this morning, many of the challenges of the fact that these processes are tangled together. They're tangled in ways that are difficult to reason about in our head. And if we want to truly understand why we see the patterns that we do in empirical data and undertake successful efforts to correct them, we need to reason consistently about these processes that give rise to them. We need to be able to test out ideas about why we see these patterns empirically and test the degree to which they are consistent with our knowledge, and then use our better understanding of how things might be working to reason about effectiveness of different changes. And absent this, the idea is we risk working at cross purposes with the nature of things, with sort of how things out there in the world work. Now, this is an enterprise which is very well known in many areas. This is a group from within Saskatchewan, with the exception of a few of our international visitors here, guest lecturers from Australia. And all of us in the room have probably at one point or another flown in a plane. We would never trust ourselves to fly in a plane unless the pilot of that plane has undergone a great deal of training with flight simulators and all sorts of weather conditions. They need to get a feel for sort of how a plane behaves in different weather conditions to be reliably entrusted with decision-making with respect to that plane in the real world. And within the health area, this idea of being able to test things out with a simulation is much more recent. It's much less fundamentally tied in to training in the health sciences, but it's an area that's rapidly rising. And it broadly falls into this category of so-called system science, the science of the whole. This is a science that helps us visualize, understand, and reason about the implications of our understanding of underlying processes and test the consistency of our understanding with evidence. And the primary tool we use in this enterprise is what's called a dynamic model. We're going to talk a lot about these models in the course of this week. Fundamentally, they weave together representations of our theory, our hypotheses concerning about how things in the world work with data, with evidence. And by representing how things might work, they can help us ask, okay, if we were to do this, if we were to do that, what would we expect? And they can help us spot inconsistencies in our reasoning about how things might work in terms of the way in which it jives or not with the world. So they serve as kind of thinking tools, ways of thinking more quickly, more deeply, and more robustly. Now, there's a variety of signs that advise this sort of approach. And I sometimes show this slide in my full-on boot camps in August to alert people to features of a situation that are sort of hallmarks of when we use this sort of modeling. I don't have time to go into these in a tremendous amount of detail, but some of them might be recognizable. I talked about emergence earlier. Does anyone remember where I said there was emergence? What did that term mean? To say that this pattern was emergent from a model or from a real-world system. Well, among other things, it means it's not reducible to its parts. It exhibits a behavior as a whole that you can't merely reduce to the parts. I used the example of a traffic jam. You could look at each car in isolation. You could know all you have to know about that car, about its engine and so on. And it's not going to tell you a lot about traffic jams. Certainly it's relevant a little bit. After all, if the car breaks down a lot, it could cause a traffic jam. But it doesn't itself define what a traffic jam is or tell you about, give you all the information you need to reason about traffic jams. Emergence are these patterns we see, like traffic jams, like backups in terms of waiting lists, the dynamics we see in oscillations in certain areas of the healthcare system. Those are emergent patterns that you can't just reduce to each piece of it. That's one of the main features you see in complex systems. But there's other features too. Feedbacks, cases where a change in one area of the system ripples around and causes changes that either amplify or push back against that original change. So maybe you add bed capacity to your facility. You have more beds for people, and you think, okay, great, we'll be able to handle more cases. And what you'll find is those beds fill up pretty quick, and you're back up to the high level of capacity. You're back up to the level of demand you needed earlier. So that's an example of one type of feedback. But there's others, adverse feedbacks. There's cases where under pressure, early discharges may occur, which seems to deal with lowering the backlog. You're hoping for a negative feedback. Too many patients, get them through more quickly by ratcheting up pressure and moving through them. You're hoping to lower that backlog, but what you actually end up finding sometimes is that leads to early, premature discharges and representation. And now you're back to treating those patients, sometimes in significantly worse conditions. These are examples of feedback. We also will often see effects of scale. Jenny talked about it earlier. The pilot works, the full-up scale doesn't work. Very common effects in complex systems. And the effects of heterogeneity. A small group of individuals, the frequent flyers, mental health cases, people with multiple comorbid conditions, so multiple chronic diseases, for example, they may have a really disproportionate impact on your dynamics. The tail wags the dog. small number of cases, big effect. Not most cases you have to worry about. It's a smaller number that you have to be really, really careful about. Very common in complex systems. Another situation is where we have delays. We put into place a policy, but it takes a long time for it to have an effect. And that long delay is often associated with substantial dynamics of the system. Okay, so what are these dynamic models? These are models that help us represent theory, hypothesized causal relationships about how things work in the world. How do things interact there? What's going on? How does the system work? How is the healthcare system put together in the area of community care options? That's something UN is working on, for example. How does it fit together? How does it work in terms of the flows from one institution to another? How do the discharges from the acute care side lead to flows to different care options out there in the community? Models provide this way of examining system-wide consequences across the entire system of changes to one or more areas of the system. You might make a change to a small area of the system. Maybe it has to do with what work gets done by paramedics as opposed to in the ED once they arrive at the ED. Maybe it's issues having to do with interdisciplinary rounding concerning ALC patients. And you can see how that ripples out to affect the occupancy and long-term care facilities, use of convalescent facilities or transitional care units, and how it ends up affecting representation at the ED. So these models help us and other system actors to understand vulnerabilities of a system, areas where we may be vulnerable to big swings or to big surges where we wouldn't have anticipated it. Ways of fruitfully changing system structure. If we put in place a more robust transitional care unit here in Saskatoon, how might it affect things? If we could get much more effective home care delivery, how might that change the system effectively, or effective respite care, and improve ways of working together, having people at different areas of the system work together more effectively. So what are these models? Okay, they go by many names, and this is one of the very confusing things. Some people call them mathematical models. Some people call them causal models. There's various sub-varieties: agent-based models, system dynamic models, discrete event models, compartmental models, models of the physics of the system, models of the plumbing of the system, models of the mechanics of the system. You'll hear these different terms, but they basically relate to the set of models or different subsets of it that I term dynamic models. The models that posit a certain causal structure and help us understand the implications for the behavior over time. Okay? These are mechanistic models is the term for them. They kind of depict how things work in the system. Not merely associations, but what impacts what. The physics of the system, as it were. In the same way that a pilot simulator for a plane helps you understand, how does putting thrust into this engine accelerate the plane, or how does deploying the wing flaps slow it down. So it is that these models have depiction of the system. Now, this is key to understand how they work. This is one of the most key points of understanding. They simulate in a step-by-step fashion the evolution of the state of the system over time. Fancy words. What do I mean by that? Well, we have a population depicted, for example, maybe composed of individuals, and the model plays out in a simulated fashion, step by step, year by year by year, or day by day by day, how that population evolves. And its interaction with care facilities, for example, its interaction with clinicians and with resources such as beds or such as diagnostic equipment, and lets you sort of play out over time. At any one point, you're at one time and you're playing out, and you're seeing how does the the health state of different individuals evolve? How does the level of resource utilization of the MRI change, or how does the level of busyness associated with a particular clinician change over time? And a key thing, folks, is because this is posited to capture causal structure, because we're describing our theory of the system, we can ask about situations we've never seen before, about counterfactuals. We can ask, what if this were different? What if we had a big transitional care unit? What if we had this major investment in respite care? What if we had a more effective home care delivery service? What would the change be throughout the system? So they allow us to ask about counterfactuals because they focus on capturing the theory about how the system works. Not merely associations, but theory. So these are the key aspects of dynamic models. And you would have seen it this morning, right, with that model that we saw. We saw, as we simulated, we saw all that flashing going on. That was step-by-step evolution of the state of the system. At any one point, a person was either recovered or susceptible or infected. They had a certain number of people they were connected to. The clinic had a certain number of people flowing through it. That's the state of the system. Fancy terms, but it's current situation, the current status of the system. And then we were simulating that over time. It played out over time, and those graphs got populated, reporting what was going on. And we could ask about counterfactuals. If we had one clinic, two clinic, if we incorporated behavioral counseling, if we incorporated this element of staffing change, that model has all those pieces in it. You know, if we staffed up the number of nurses at this place or the number of counselors, how would it change things? And I mentioned this is tied in very centrally with modus operandi, standard operating practice in many other areas outside of health. Whether it's, process plants or driver training or just reasoning about traffic flow or pilot decision making, these sort of simulators are par for the course. They're to be assumed in training in many areas, especially areas where life and death decisions are being made, such as in flight training and nuclear power plants, etc. So I mentioned earlier, yes, Jeff. Oh, turn that down. Okay. Let me move it to a lower point in my vest. Is this a bit better? Okay. Apologies. Bad enough to hear my voice, but to hear that static atop is really something else. Over the top. Okay. So I mentioned Jeff's analogy here, learning models as a learning prosthesis. I didn't really get this until I broke my foot and sprained my ankle last fall. And I learned about the many virtues that recommend prostheses. Prostheses basically complement our limitations, right? So I had this broken foot and I had this boot on, and I would limp around, but it basically helped me overcome the limitation of my foot to a large degree. It helped me get around and even give lectures despite my broken foot. Models are kind of like that because we as humans are really good about reasoning certain things, spotting patterns, etc. We're great about negotiating in complex situations, and we have exquisite abilities in terms of recognizing certain patterns. But we're not very good at certain things. And one of the things we're not very good is in reasoning quantitatively in a highly precise way about the implications of diverse assumptions. If you precisely specify how I assume this area of the system works, that area, we're not very good at adding that up in our heads. It's not something we're built to do. And yet, computers are incredibly dumb things. They're incredibly sort of limited in many areas compared to us as humans. But they're extremely good. Their foremost strength is in totaling up a lot of a lot of calculations, and just being brutally consistent about saying, okay, this plus this equals that, and totaling all those implications up. So models here, as programmed on a computer, basically complement our limitations. They do the things that we are weak in, and they help us thereby think more consistently through the implications of our assumptions. So if we have a model that represents this is how things work, what is the implication in terms of this aspect of system behavior or that component? So they help us reason, again, consistently, quickly, thoroughly, and more robustly. Now, it's not a matter of models, and this is a key point, models against evidence. No, it's models to make sense of the evidence, to help us understand the degree to which our understanding of the world is consistent with that evidence. You know, you can have all sorts of evidence brought to the table, but it's not immediately obvious to us the degree to which it's consistent with how we think things work. And a model can help us spot those inconsistencies much more quickly, and thereby help us, you know, evolve our understanding of how things work in the world. So a model is not a crystal ball that either works or is shattered by falsehood. It's rather a way of kind of thinking through how things might be and learning more quickly from the evidence and guiding us as to what additional evidence might be most valuable. So it helps inform our choices and advance our understanding on what data to collect or what interventions might be most effective. So there's this kind of coevolution going on with how we think the world works, this kind of what I call a mental model, many others call mental models, by capturing it in a runnable model, such as we saw earlier. We could see the implications over time of that model, and we can ask to what degree is it consistent with, does it jibe with, to what degree does it align with what we see from the world, and we can actually use it to motivate collecting additional information or undertaking certain interventions in the world. So it's part of this learning loop that helps us learn more quickly. In the same way, a pilot in a plane who's going to be flying in a plane uses a flight simulator to learn more quickly how to most effectively work in a thunderstorm, how the plane would behave under wind shear conditions in a driving rain or what have you. So these models are part of our sort of ability, they form part of our ability to learn. So if you go talk with my colleagues in the States, particularly Josh Epstein at Johns Hopkins and Don Burke who's the Dean of the School of Public Health at Pitt, both avid modelers and very prominent voices within that field, they've cataloged dozens of uses of models, dozens of them. You can use models this way, that way, and you can go through that list, and it's quite a remarkable set of sort of cataloging of how people have used models. And there's many uses of them we won't have time to capture in the boot camp, but a few of them I want to highlight. Perhaps the biggest one that motivates their use these days is to ask these what-if questions about counterfactuals. If we were to do this, if we were to invest in this intervention, or this combination of interventions, this intervention portfolio, you know, what yields the biggest bang for the buck? What yields the biggest, highest leverage results, most effective? What things are robust given our uncertainties about how the economy will evolve or about changes to health behaviors? They can help us evaluate benefits of restructuring the system, to understand trends, make sense of data that has maybe different interpretations, to help us prioritize the research and data collection by identifying uncertainties that are particularly key, that are particularly sensitive in terms of making choices, or to identify inconsistencies between what the model suggests and the actual data seems to suggest. And understand classes of contexts where certain strategies can be applied. So they can help us take that learning from Toronto and translate it more effectively into Moose Jaw. Finally, they serve as really potent learning labs, vehicles for working with individuals of diverse background. Okay, so we noted that these models depict an evolving state of a system, a number of the the people who are in the clinic and what stages of workup they're engaged in, the status health-wise of each person in the population, etc. How do they do that? Well, basically, ladies and gentlemen, we provide mechanisms that specify, given your current state that you're in, how can you change? And you may remember that earlier when we ran the model, just like I just ran. So remember when we saw this. So if you're in this state here, you can evolve, say, and become infected. If you're in the infection severe state, you can recover, or you can go back to susceptibility through treatment. So they specify how things can change in a very quantitative way. What I'm not showing you there is the precise specification, but if you were to go click on these things, if you were to go click, for example, on that recovery transition, you'll find that this occurs after exactly duration of mild infection in days time. Okay, so there's some way in which we specify, given your current situation, how can things change? And for example, if you have lots of people and it's currently in the acute care wards, the incremental changes, it may lead to more discharges. If nobody's in those wards right now, you have a brand spanking new hospital, there's going to be no one discharged. It depends on the state. What changes depends on the current situation. System behavior is emergent. We don't program it in. There's nothing in our model that says assume this gradient over income. There's nothing that says make this graph that looks like this. Rather, that emerges from the interaction of this theory, given the data that's there over time. So we can't generally write a formula for how this model will behave over time. Rather, we have to run it. You could take Einstein and you can put him with many of these models, and he's not going to be able to write down an expression for how it'll change over time. Rather, he's going to have to use a computer to simulate it out over time. It doesn't have a closed form, as we say in mathematics. And generally, the systems that these model are nonlinear, and as a result, the models need to be nonlinear. This is a fancy term. It's used in many ways, and it's misused in many ways. Here, it speaks mostly about how the whole is greater than the sum of the parts. We can't simply take the behavior of the whole, the traffic jam, and reduce it to each of the cars there. There's an interaction that's absolutely key. We can't write down a formula for exactly how the number of patients discharged from your acute care within your favorite hospital will evolve over time. There's counterintuitive behavior because of this feature. Now, this is key. Those things are interesting. I mean, they're intellectually interesting and have spawned no shortage of fascinating work. But when it really comes to practical consequences, the way nonlinearity matters is if you have multiple interventions, scaling up a given intervention, think this, does not necessarily lead to just an appropriate doubling or tripling of the effects seen at smaller scales. So if you double the size of the intervention doesn't mean double the effect that you saw earlier. It may be totally different. But more than that, multiple interventions may be synergistic in big ways, or they may work across purposes. There's history and path dependence. What goes on going forward depends a lot on the situation earlier. We know that in health, early life insults cause big differences in later life outcomes over the life course. And so it is at the system level as well. You can get lock-in to a situation where a ward's constantly in flux and fighting fires, or one that's working smoothly on an ongoing basis. And once it gets stuck in that mode, it's hard to get out. Much harder to get out than it is to prevent it from getting in the first place. And I noted this tail wags the dog, where small subsets of the population make a big difference. So let's talk about this analogy of models and maps. Some people find this quite compelling. I do, amongst others. Models So George Box once said, the famed statistician, all models are wrong, some models are useful. And I would say that's true, but you got to understand what wrong means in this sense. It's in the same sense that maps are wrong. So many of you may have used a map to get here. Maybe it was a map of Thorvaldson. Maybe it was a map of the campus. Maybe it was a map of Saskatoon. Maps, like models, represent abstractions of the world. Fancy term, abstraction. What am I talking about? I'm talking about they represent the world, but with some simplifications. That map you used to drive across the city to find this, to Science Place, that map didn't have every blade of grass, it didn't have every tree on it, it didn't have every crack in the sidewalk. But it was useful for your purpose. It hid a lot of detail, and it was useful because of it. If it had all those details, it wouldn't have fit in your car. The only perfect map of the world is the world itself. Instead, it's the ability to omit details that make maps useful, make them convenient to use, right? But we use different maps for different purposes. And models are that same way. Like maps, models are specific to a purpose. We build a model to investigate this phenomenon or make this decision, and we omit certain details, we capture other key details. And the model, like a map, is wrong in the sense that it omits a lot of details, but it may capture the essential features to allow us to reason reliably about the situation. Over time, by helping that learning, by serving as a learning prosthesis, it helps us get better and better and better and more reliable our understanding of the world. So models and maps have many features jointly, and models like maps are specific to purpose. Okay? Now, I love this quote. It's actually not a quote, excuse me, that's a quote of myself. Actually, there's a much better quote by Francis Bacon that perhaps Jeff can, it is easier to evolve truth from error than from confusion. Yes, okay. Now, it's actually in Latin, and it's been translated several different ways. It's easier to evolve truth from error than from confusion. What Francis Bacon was alluding to there is going out and trying something and making an observation from it. Even if you're off base at first, you learn something and you advance your understanding. Sitting there, just leaning back and say, well, we don't know what it is not going to get you very far. And with a model, we have a way of replacing mere confusion, just keeping things in our head about how things work, with learning. We have, by putting it in a place where we can have a computer that will reason consistently about its implications. Even if our understanding is wrong, we'll more quickly get it towards a side where we start gaining real understanding. By supporting theorizing concerning what's going on out there that might explain these patterns, we can build theory more effectively, we can test that theory, and we can correct that theory. We can help falsify it and put in place a better theory. So often putting forward even a poor model advances our knowledge by helping us spot these inconsistencies between assumptions and evidence. We are not here, ladies and gentlemen, in the position of saying we need the perfect crystal ball or nothing at all. Rather, we try something, we observe the degree to which it's consistent, we try to collect evidence which will inform its areas where we're uncertain, where a lot of that evidence is talking to people. It's a theory, not merely data. So a common consideration for all these models has to do with model scope. It's really what's in the map and what's left out, what's in the model and what's left out. And I want to distinguish for these sort of models a very important distinction you don't see for most statistical models, models that are of different character. And this distinguishes between things that are endogenous, things that are exogenous, and things that are ignored. What do I mean by things that are endogenous? These are things that the model calculates, it produces, it generates. They're outputs from the model, not in the sense that they only go out. They may also influence other things, but they are calculated by the model. It is producing them. We're not telling them to it, rather it's telling us. And for example, in that first model, that graph we saw that had the gradient between income and number of times infected, that was something that was generated by endogenous factors. It was calculated internally, that relationship. We didn't tell it. By contrast, there are certain things that are exogenous. We specify to the model. We say, assume that you retain that the rate of waning immunity for this infection is such and such. Assume that there's this many clinicians on staff on the ward at this time. Those are things which are specified to the model. It's not producing them. It helps us understand the implications of them, but we're telling the model this. By contrast, the endogenous things, it's telling us, what the consequences are with respect to those things. And then there are certain things, inevitably, which are ignored. The blades of grass, the trees that are omitted from your roadmap, those are ignored, and so it is that some things are ignored with our model. Some things are just left out, often consciously left out. We say, we haven't yet put it into model, we're not sure it's important enough, we'll leave it out for now. And over time, ladies and gentlemen, things tend to evolve here. As your model evolves, and critically, your learning evolves, things that were previously exogenous may become endogenous. You'll endogenize aspects, for example, of the care network. So we all know a person's path through the care system, particularly in older age and in younger ages, is fundamentally shaped by informal caregivers. Think about a patient with early signs of dementia. How soon they end up in institutionalized care in a dementia ward will depend very critically on their network of caregivers. And not purely so. Also, there's interaction with formal caregivers, but the informal network is there as well. We might initially have a model of the whole healthcare system, and UN will present elements of that model tomorrow, showing patient flow across the entire system, where there may be some assumptions made about informal care at some level, but it's specified to the model. Conversely, there may be models that we wish to consider where we endogenize that. We actually simulate the effects of dynamics associated with informal networks. Why would you do that? Why would you go from a situation where we just say, okay, a person has these networks and effects in what long-term care facilities they're placed after discharge? Why would we replace it with a situation where we might actually represent those individuals in their care network? What would be the benefit of that? Why would we want to represent people interacting with this patient of focal concern? Okay, so if we wanted to, great, that's exactly it. Let's make that more concrete. If we wanted to examine the impact of investing in respite care, of having some capacity for improved elder daycare programs, or to have elders placed within long-term care facilities for care, or other facilities for care for some defined time, while a caregiver has a chance to recover, an informal caregiver. If we want to understand the implications of that for the care offered, it might be pretty helpful to reason about the dynamics of burnout in informal caregivers, right? That if we provide more respite, they'll be less burnt out, and therefore they may keep that loved one. They may be able to keep that loved one in their home for a longer period before thinking about institutionalizing them. They may visit that loved one more often and catch health issues, whether it's signs of a TIA or aspects of an early infection in the foot, or issues having to do with a urinary tract infection. They may spot things sooner, get that person in for care because they're there more frequently, because that respite has made the big difference in their morale and their ability to cope and not feeling burnt out. And if we wanted to understand those effects, endogenizing, simulating sort of how people get burnt out, how people recover through provision of respite care might be pretty important. Might be pretty helpful for understanding the different trajectories. The trajectory for that person of focal interest, the person with early stage dementia perhaps, but also understanding some of the health issues associated with that caregiver, depression or other components. So this issue of what's exogenous told to the model, just assume this certain level of care on the part of informal caregivers, and what's simulated within the model as part of the dynamics of the model, that's a big distinction that you have to be clear about with these models. What is it that's generated? What is it that's just told to the model? At a deeper level, Richard Feynman once said, a Nobel Prize-winning physicist that some of you, whose popular books you may know of, he once said, supposedly this was at the time of his death, this was on a blackboard that he would use. He said, what I can't generate, I don't understand. If you can't explain patterns by generating them without presupposing them, you don't fully understand what's going on, what lies behind them. So endogenizing factors often help us kind of reason through issues more fully than we would otherwise. So capturing more factors endogenously adds flexibility, allows us to investigate additional intervention options, for example, or have extra explanation. But it does require more time and resources. It's more challenging to reason about often, and often it means drawing on a much greater variety of expertise. So let's talk about a few take-home messages before we break for lunch. Addressing many larger health and healthcare challenges is especially hard because they exhibit features of complex systems. We see patterns there that are not reducible to their pieces, and yet we want to change those patterns, and we're not sure how to do it most effectively. And system science, this emerging science, it's been around for a couple decades now, but it's really gotten big steam because of larger scale recognition of its relevance in the health area. It provides us with tools to represent and reason about behavior of complex systems. Again, people in other domains have been doing this for a long time routinely. Think about the flight simulators. Think about the process models. But here within the healthcare area, this is much newer. A lot of people are getting exposed to it for the first time. These models express dynamic hypotheses, these sort of best guesses how things might work out there, so that we can reason through the consequences. We can reason about the degree to which, among other things, those assumptions jive with what evidence we have. So the models help us understand critically how interventions might affect health disparities or healthcare system function, and how factors involved out there in the population yield observed patterns. These models are specific to purpose, ladies and gentlemen. They're specific to certain goals. We will build a different model for different questions often, but certain models may be able to address several types of questions at the same time. And multiple hybrid modeling types are out there, these system dynamics models, agent-based models, discrete event models that are complementary for describing complex health challenges. And we'll be looking at those starting this afternoon for different types of applications, so you can understand, kind of parse what sort of model types are there out there that can shed light on the needs in the health service delivery area. Okay, so those are all my comments for now. We have a lunch planned and a guest lecture by our esteemed Australian doctor and engineer, Jeff McDonald. I'd invite the TAs to help lead the group over to the faculty club where we'll be taking our buffet lunch, okay? Thanks very much.